Our January Trust Board meeting, and welcome to those who might be watching our proceedings this morning. I'm Caroline Flint, the Trust Chair. I just want to start by welcoming a few people to our board meeting today. Sue Corden, who is here from Grant Thornton. Sue is working with a team of people leading an external well-led review of the organisation. Sue, welcome.
Thank you.
Also, Stuart McKinnon-Evans. Stuart is here today. He is our newly appointed audit chair, and he is starting with us in February. Welcome, Stuart.
Thank you very much. Good morning, everyone.
You're very welcome. Just want to say that Hanif Malik, our associate Ned, is joining us around 10:30. He's actually attending on our behalf this morning a health inequalities seminar that's been organised by NHS North of England. And just to mention that Mike Smith, our Ned, who is with us, is having to leave early today, unfortunately, to attend a funeral. So, but just to say he will be with us, and that's why he's leaving. So thanks for letting us know about that, Mike. So let us begin. Are there any other apologies for absence? I don't think so. I think we have a full house.
We do. Yes. No more.
Thank you. So we will be quorate. Declarations of interest. If there are any changes to declaration of interest, as I normally say at these meetings, please inform the company secretary. And of course, if there are any items on the agenda that cause any conflict, could you please let us know and remove yourself for that item? Okay. Moving on to the minutes of the meeting held on the 24th of November 2021. Are there any corrections to those minutes from anybody? Can't see anybody. No, thank you very much. So moving then on to the action log or matters arising. Any comments on minutes or the action log?
Chair.
Francis.
Just to say, on the first page, the bottom one asked for the agency deep dive to the Finance Committee, and that was done, and I'll report on that later on the agenda.
Thanks very much, Francis, for flagging that up. Any other comments, please? I can't see anybody, so can I say that we will approve those? Yes? Thank you very much. Moving on then to the item on our agenda, which is usually a patient story or something from some part of our organisation and to tell us how their work they do. But today we have a presentation on the annual quality health survey. And John, you're going to introduce our guest, Charlie, who's presenting today, and some other colleagues who are with us to answer questions. Thank you, John.
So good morning, Chair. Good morning, everyone. Those of you who've attended board meetings over the last 4 to 5 years will recognise that this is a regular item on our agenda when we discuss the details contained in the report produced by Quality Health. I won't steal Charlie's thunder. She's coming from Quality Health, so she'll explain what the survey is. But also in attendance today, we've got Mandy Dawley, who's the Head of Patient Care Experience, and Paul Johnson, who's our colleague and clinical lead in the mental health division. So we will talk you through what the Trust has been doing, dare I say it, over the past 4 months since we started to gather some of this preliminary data, explain some of the work plans in place, and just provide assurance to the board that this work plan has been through EMT and indeed is noted in the EMT minutes as well. So Charlie, shall I pass over to you without further ado?
Sure, thank you very much. I think it's the first time I've been introduced as a she, but to be fair...
So apologies, Charlie.
It's usually my colleague Jenny, I think, who presents to you.
It is.
He is a she,
yes.
So I understand the confusion.
So apologies for that, Charlie.
That's all right.
I think that's a system one safety error. I was you changed things around. You shouldn't have done
that. Morning, everyone. Thanks for having me. It is usually my colleague Jenny, I think you see. So she's not available today. So I'll be taking you through the results. I'm just going to share my screen, and I'll check you can all see that before I kick off.
That's great, Charlie.
That good? Okay. If I could take questions at the end, that does work best, just because while presenting, it's difficult to see various hands go up. But do stop me if there's something you really want to ask about then and there. If you could just raise your voice, unmute and raise your voice, then I can hear you. If not, if someone else could keep an eye on hands going up, that would be great for me. this is the annual Community Mental Health Survey. It's a survey we run on paper only, so there's no electronic survey. It goes out to your service users in the post. And this is slightly delayed, this presentation. We normally present to you sort of towards the end of last year. So the survey fieldwork ran between February and June 2021, so it's almost a year old, but it's a long fieldwork period, so it started in February. As I go through, there's a lot of comparative data which shows you how you're doing compared to other trusts. Now, it's important to say that when we present this, we only include the trusts that we work with. However, we work with almost all of them, so it's 93% of the total trusts who are surveyed. So the figures are rarely change at all, if at all, very slightly when you get the combined report. Looking first at response rate, you can see you've gone up very slightly, which is really good. So the national trend is downwards across the whole survey, most likely to be due to the pandemic, as you would expect. So the fact that your response rate has gone up very slightly, albeit it looks like the same number of surveys have been completed, the sample's a bit smaller. That's really encouraging. Just to hold your own in that sense suggests that there's an engaged group of service users. So this is the breakdown of all the scored questions, and we score them if you look at the management report in this sort of in a RAG rating, red, amber, green, and you've got the top 20% of performing trusts, which is the you've got 5 in that category. Then there's the intermediate 60% range, in which you've got 20 odd scored questions. But that's a high number, obviously 71% of the total scored questions, and just 3 in the lowest 20%. And I'll come on to those because they're the ones I imagine you will want to follow up on. These are quite encouraging scores. I think it's really important to point out that the nature of care provision during the pandemic was very different. And as such, it has affected survey results across the board, both for patients and for staff who are working in NHS trusts. So trusts who have results that look like this, lots of stuff in the middle range, are actually doing much better than you might normally think. It's just important to point out. So these are the top 5 questions. This is just purely out a score, the top 5 questions, not necessarily your top 5 compared to others, but in terms of your actual score per question. These are your top 5. Really good one at the top there, which is service users knowing how to make contact if they're worried at all. Really high score, which is great. And the score, question 19, I just want to point out, because I'll come on to that, around crisis care is really encouraging, which is service users knowing how to make contact. But we'll come on to what they say about the level of support that they receive if they do. And these are the questions that are low in their own right. And the one at the bottom there probably is one of the ones you want to look at, which is around side effects of medications, because that is noticeably lower than other trusts. And the middle ones there, 33 and 34, are those ones in the support and wellbeing section, which the CQC is actually quite interested in. And that's how trusts are supporting service users with financial advice. And then the one below around access to employment opportunities. They're really important ones to sort of keep your eye on. But lots of trusts dipping across the board in those areas. Because access to those services was restricted during COVID, and or some services just closed completely, partnership with third sector organisations, for example. We'll come on to those. So there's a few slides now that look like this. I'm really sorry. They're a bit busy, but I will tell you about the most important things on each slide. And don't worry, I'm not going to talk to every number. So just what you really want to look out for is green arrows rather than red ones. And they indicate a significant change from either from last year or from the difference with your sector score, which is the score at the end. That's the overall score. So the top one there is a really important one to point out. So it's did service users feel they were seen often enough for their needs? And you'll see that's dipped. Now, of course, a question like that is almost it's very likely to be down to COVID and the fact that service users weren't being seen, or were being seen in inverted commas remotely. So a drop from 65 to 57 is noticeable, but you will see you're still in line with, broadly in line, slightly below the overall score of 58%. So one just to keep your eye on, and what we're telling trusts at the moment is those that have the trusts that have found they've been quite successful here is writing to service users in advance of appointments and making it clear that the telephone appointment they might be having, or the telephone review of their care, replaces what they would normally have had when they've been seen face to face. And so they understand that they are still being seen, if you like, albeit not necessarily face to face, but hopefully some of that will pick back up anyway. On the second table there, which is around health and social care workers, a dip between 2020 and 2021 around service users feeling they've been given enough time in an appointment. Again, that might be because they're not attending face-to-face appointments. But if there's an issue around remote appointments they might be having, that's one to have a look at, maybe drill down into your data a little bit. And the second one, question 8 on that table, I think comes through the survey quite clearly. There's a need for some service users, they feel, to be more involved in their care than perhaps they are currently being. So this one is around how the health or social care worker understood how their mental health needs affected other areas of their lives. But there's also some questions on involvement which have dipped a little bit. One to keep your eye on, but again, none of these are significantly below the overall score, so none to really worry about. Organising care, the one at the top there's dipped slightly, so service users knowing who's in charge. But a fantastic score around knowing how to make contact if they've got a concern. I mean, I think you're one of our top performers there, if not our top performer. So that's really encouraging, the fact that service users are clear on where they need to go. Planning care, the really important one here is the middle one, the one the CQC we know are interested in, which is around how involved service users feel in agreeing their care up front. And if you score well on question 15, you generally score well on question 16, which is feeling that their other areas of their lives, are taken into account. So both those scores have dipped a little bit. Again, it's important to say they've dipped across the board. And both of those are broadly in line with the overall scores, but ones to keep your eye on perhaps. Reviewing care is one of the most important areas. So question 17, there's lots of evidence that this links to other core areas of the survey. So when you do well in question 17, you generally do well in quite a few other areas around feeling involved, service users feeling they've reviewed their medication, and other areas of overall satisfaction. So it's a really important one to get right. Now, obviously, because it says, have you had a specific meeting with someone? And lots of people may not have had that meeting due to the pandemic. That is why this score will have dipped for you, I'm sure, and has dipped in every organisation we've worked in. However, it has dipped quite significantly. So, and is now just a little bit below the average. You were doing really well on that, I remember last year. So it might be one to look at. There might be something else other than the pandemic that's affected that, that you're aware of. But again, the communication with service users in advance of that meeting is the thing that can really drive that score. So in an appointment letter, making it really clear that this meeting you are having is your specific 12-month opportunity to review your care, et cetera, making that really clear. Those trusts that have done that have scored quite well in that area. Crisis care below there is broken down into 2 questions, and there's the first one which asks the service user, do they know how to make contact when in crisis? And the second one asks them if they did make contact. So it's only of those who contacted the crisis team, did they get the help they needed? So fantastic one above in terms of service users knowing how to make contact. And that's really been quite difficult for lots of trusts to get right. So a really encouraging score there. And I hope ties into activity you've done to promote the crisis care service, because it's clearly had an effect, even during a really challenging time. Slightly less positive on the support that they might have got if they've contacted the crisis team. I don't think it's an area of concern. If you'll see your score is 61.5% and the national average is 65, so you're a few percent behind it. But it's dropped noticeably. It's one you might want to have a look at and maybe understand if there's anything going on there. Medicines, the big ones of medicines are service users being told about side effects and danger signals, things to watch out for. And that one's dropped a bit, if you can see, between 2020 and 2021, gone down 5% or so. The thing that really helps with medication and side effects is giving service users printed materials, which explains their medication, so they take something away with them. again, if they're not seeing someone face to face, that I'm sure that would have affected that score. And it's not an area of concern, but it's one as a trust I'm sure you want to look at. And question 26 at the bottom really ties into that other 12-month review meeting. When trusts score well here, score well in the other area, they score quite well here. NHS therapies, these are new questions, so no comparable data, but a really good score around service users feeling involved in decisions around NHS therapies, well above the national average and one of our top performers in that area. So that's really good. And I wonder if service users could be involved in other areas, particularly around discussing their care up front. Almost there. So support and wellbeing. This is the section I talked about at the beginning, and it's pretty important. In particular, the CQC, when we hear from them, are often talking about this access to employment and our service users being given advice around finance, financial planning or benefits. So the financial benefits one has dipped slightly. Again, we've noticed this across the board. So this could be due to services closing and or partnerships closing down or just not being available. So a bit of a dip in finance, that's the one to look at. The employment score is actually still good. You've always been really good around on this score, and still well above average, even with a drop. Obviously, we always say flip it on its head, and although that's a really good score compared to lots of other trusts, it's still under half. But that is the case across the board. And then finally, that one around involving family members, and have the family been involved as much as they can or as much as the service user would like. Around average now, but again, a bit of a dip. And again, I don't want to keep saying it, but I'm sure due to the nature of care provision, during lockdown, I'm sure has affected that. So overall experience, it has caused overall experience to go down. So they're asked to score at 1 out of 10 and you get an average percentage here. But if you look, it hasn't really affected how you're doing nationally. You're around average nationally. Really good scores on respect and dignity. And as I say, one of your best scores is service users being asked for their views outside of this formal mandated process. Really good score there, well above average. So just a few slides on recommendations, and then I can take some questions or comments even. So care and treatment, the feedback there was around service users being seen often enough for their needs, and maybe some work around communication in advance that their appointments might have been paced by a remote appointment, and this is a formal opportunity to do X or Y, and just making that clear up above. The feedback around service users, around health and social care workers, was about service users feeling they had enough time to discuss their needs and treatment, and that they feel involved, so that the care that they're being offered takes into account other areas of their life, perhaps. Organising care, just continue great work on making sure service users know who's in charge so that they know where to contact if they need to. Planning care, again, it's the same as the other recommendation I've just said, really, which is around making sure service users are involved as possible. Within reviewing care, it's the one I've just discussed, but it's there because it's really important to continue the work around that. As I said, it affects lots of other areas of the survey. So maybe some additional work in communicating with patients up front about 12-month review meetings, and that they might be happening remotely, for example. Crisis care, great scores on knowing how to make contact when in crisis, really encouraging. But the level of support, it's in red there because that's one of your scores that's in that bottom 20% range of the three. So definitely have a look at the level of support being provided by crisis care. Medicines is the other one one of your three lower scores is side effects of medications. I said there, printed materials are proven to help. There's some evidence around that, but that might be difficult if you're not seeing patients. But definitely have a look at that score. It might be a particular demographic that's scoring that in a certain way, and some targeted work could really help. And the second one around medications was being given opportunities to review how they're getting on. And finally, support and wellbeing. The scores here are still quite good, so don't panic. But the one that noticeably had dipped was around financial advice and involvement of family members. And I'm happy to take some questions. I'll close my presentation so I can see you all. I think it's really important finally to say these are actually really good results. in a really difficult time to deliver care to service users. To be around average might not be what you would normally aim for, but actually is quite good. So where the national trend has dipped quite a lot, your trust has definitely dropped less in certain areas. So actually, these are quite encouraging results, even though you might not see them that way. They are. Happy to take any questions.
Thank you very much, Charlie. That was a really helpful and clear presentation. And I presume you will be able to have those slides for us to look at in more depth.
Yep, absolutely. They're yours to keep.
Thanks very much. Just before I bring everyone in, can I just ask a question? Just when you were going through the slides, you had the figures for 2019, 2020, 2021. Obviously, 2019 was pre-pandemic.
Yeah.
And actually, the figures in some areas for 2020 went up. And then they've got down. Are you having should we be having a look at, because clearly when the first year of the pandemic, actually our score went up in some areas. Is that worth having a look at?
Yeah, I think so. Bearing in mind that it would have been right at the beginning of 2020 when the field work took place. So some of it might have been pre some of the lockdown, but yeah, it would definitely have been during some of it. It happened quite early 2020, didn't it?
March.
Sort of March, yeah, of course.
Yeah. Okay, thank you very much. Right, I can see a number of hands that have gone on. Francis.
Thanks, Chair. A couple of points. So Charlie, yeah, I'm picking up on your fact that definition of being seen, the interpretation on that is fairly key. Do you think within this there's some backlash against people? We've seen it with GPs about not wanting to be seen online, and there's almost a pushback in the survey because of the fact that they prefer to be seen face to face than online.
Yes, I think almost certainly, and we haven't obviously asked the question, so we can't say with certainty. But on other surveys we've been doing with patients where we've asked those questions, so there's a number of NHS surveys that specifically ask around COVID-19. Lots of people are resistant to it and feel they're not getting the same level of care if they're not getting to see someone face to face. So I'm sure that has affected it. What we've done as a result of this survey this time around is fed back to the CQC and NHS England around the wording for that question, and if that can change in future iterations of the survey, so that it says something like this appointment may have been over the phone, for example. Because at the moment it really sounds very much like it's about a face-to-face appointment. So yes, agree. I think there is some resistance, and you'll probably know if you look at some of the free text comments you get alongside the survey, will probably say some of that.
And that therefore would probably impinge on some of the other questions as part of that bad feeling.
Yep. Absolutely. And 12-month review, all those ones. Yeah.
And then on that medicine question, because I've had a couple of sessions myself online, they actually sent me the detail by email. So probably not a question to you, but maybe into the team. Do we do that? Do we email out details of medicines as part of that? So I've had 2 online consultations over the last 18 months, and on both they've then said, we'll email you details about your treatment and medicines so that you've got that. I don't know, again, that's for the team rather than you.
That's great.
I'm seeing Lynn nodding. Do you want to give a quick answer to that, Lynn?
Is that something you want me to come in on here as well?
Paul.
I'll start, Paul will bring you in. But yes, we often follow up consultations with service users, with patients, Francis, with emailing the relevant information and advice, particularly around medications. So, but I'll let Paul, I don't know if there's anything you want to add to that.
Yeah, just again, it's around that we aim to try and ask people's preference of how we communicate, and one of them is email. And we will send information out on email. Some of the work that we're doing around medicines at the moment is strengthening that, and actually looking at the medicines packs and information, whether that would be sent through the post for some people, if that would be appropriate, handed over, or via email. And it's just making sure that we have that consistent approach for everybody.
Thanks, Paul.
Thanks.
Is that all right, Francis? Good.
Yeah, that's great. Thanks.
Mike.
Thank you, Chair. Thanks for the presentation, Charlie. Absolutely excellent. It's a shame we couldn't spend more time on it with the whiz through. Some really positive stuff in there and some big watch out for us. Just thinking about the fantastic score for patients knowing where to contact in crisis, and a less than fantastic score about how that crisis is dealt with. Are you seeing any evidence of the pressure outside in the system, lack of step-down care, lack of crisis accommodation and so on? Does that come out in the free flows, that the trust was great but we couldn't get anything outside?
I'm not sure is the answer to that one. We haven't. I haven't looked at the free text comments, but someone else might be able to answer that better than I can. Lynn, did you put your hand up?
Leave that one hanging, but I'm just trying to think how much we're affected by pressure outside in the system.
Yeah, I'm sure very much so. And we can have another look at those comments. I'm not sure what's happened with the free text comments. I think it's an extra piece of work if we do thematic analysis on them, for example.
Yeah, just for the public benefit. I'm not looking for excuses. I'm looking for where we need to
absolutely. Pressure. We'll have a look at that for you.
Yeah, thank you.
Paul, is there anything you want to say about that? Sorry to interject, but Paul, is there anything you want to say in response to that, being at the front?
Yeah, I think, Lynn, you popped your hand up as well. I don't know if there's anything you want to add here.
Well, I was going to bring you in, Paul, because the timing of this survey is quite important. And the board might remember that last year I did bring an update around changes that we were making to our crisis of June, July time. So they wouldn't have been fully captured in this survey. So, for example, we significantly increased the support that was available on the 24/7 crisis telephone support line, with the further development of the work that we are doing with Holland East Riding Mind. Because during that period last year that this survey covers, we saw a further increase in demand through to the crisis team, quite a significant rise in demand. And we were fully aware that, therefore, because of that increase, our focus and ability and capacity around supporting those service users who really were in crisis was impacted by that. So the Mind telephone support line was really there to support particularly those service users who were at the sort of, criteria that didn't need necessarily that intensive support from the crisis team. That has meant, and we can see that through the data, and Paul might want to add more, that the capacity and resource has been released into the crisis team to really give that sort of increased focus on those service users who really have needed that support. And it's meant as well, it's had a positive impact on capacity in our home treatment service too. But Paul, you might want to add just a little bit more.
Yeah, I think we know that people who were known to our service previously have really struggled during this very difficult time, but also people that have maybe never been known to mental health services. All of us, I think, has been impacted with what's been happening over the last couple of years, and that need to reach out for support has gone up and up and up. And I think, as Lynn said, what we've been trying to do throughout this is trying to continue to review the capacity that we have within the system, and the extra capacity that we've been able to bring in with support from our third sector colleagues through Mind, through the support line, and through the crisis pad. It's been able to deliver some different options and some different offers than the usual just getting through to the crisis team. But what it has been able to do is to release some capacity so that we can increase the support that we've got, as Lynn said, within the crisis team and the home-based treatment team. This is something that we're constantly reviewing, and we need to do that to ensure that we're making sure that we've got the right capacity in the right area. So quite recently we reviewed the amount of calls and people accessing the Mind support line, and actually have moved some resources in to actually bolster that up. And we'll be continuing doing that on a continuing basis so that we can make sure we're shifting our capacity to meet the demand.
You're mute, Caroline.
Apologies. Thank you, Paul. I've got Hilary who's got a hand up. Hilary?
Thanks, Caroline. A lot of what I was going to say has actually been covered, but one of the things I did want to ask was could we start to look at changing some of these questions to fit the context that we now work in, because we're not going to go back, as we've just heard from the discussion there. This is how we're going to work going forward. We'll tailor it, we'll shift, but if we can change some of those questions, I think they are misleading. It is, people will see that as I've actually seen somebody face to face, and that is not how services are going to be delivered going forward. So I think that's really positive. I think again about how we move forward, and we said about using email and things. We've got to remember not everybody has access to email, not everybody has access even to a telephone. This is the same. These are the service users that we're working with, so we really need to think out the box, don't we? So certainly more work to do on that. We have done quite a bit around medicines over the last few months. We updated the policy very much about service users, talking to them about their medications, sent practice notes out on it, and we've also embedded that into our clinical risk training as well. So a big focus on that. So it's only been the last 6 months that we've done that, but it'd be interesting to see when we next get the survey whether or not that started to have an impact as well. Still lots more to do, but we've started the work on that as well. So I just wanted the board to be aware of that. Thank you.
Thanks very much, Hilary. Dean.
Yeah, thanks very much. I agree with others. It's remarkable, isn't it, given the 2 years that we've had, that people have managed to keep services going at all to get some of those results that you were saying, Charlie. There's just a couple of things for me, if I might. There's something about the survey. So a few times you talked about where we'd seen reducing scores as possibly a result of doing things more virtually. And I just wonder, is that supported by the free text comments, or is that just your intuitive feel? For example, it might be that it's not virtually, it could be the quality of the virtual consultation, and I'm conscious that we'll need to train staff to do things differently, won't we, in that term? So it's just, is there anything in the free text that gives us some sense that it's virtual per se, or the quality of the virtual sort of area? And then secondly, this is possibly more of a something for John and Hilary and Lynn and others, but these surveys are great, aren't they, in terms of looking at benchmarking, because it shows you how you compare. That's always good to know, but I'm also conscious that benchmarking just tells you what's common. It doesn't tell you what's good. And I just wonder, from, when we're doing the action plan, when John and Hilary and others are looking at that, are there stuff where we benchmark quite well, but actually it's still unsatisfactory? We should be doing significantly better, even if it compares. And I just wonder whether we could reflect on some of that. And it's good to benchmark, but I think sometimes just looking at what's good versus what's common is a nice challenge for us.
Thanks, Dean. Anybody like to come back on that? Charlie?
Yeah, just very quickly. I think the answer to the first question, which is a really good one, is it's a bit of both. So there are people that are resistant to any form of virtual appointment, and so are therefore really unhappy with the fact that's how it's moved. There are others who are actually quite pleased with it and prefer it. Means they haven't got to leave house and perhaps make a difficult journey. And then there's a cohort who are attending all the appointments because they feel they need to, but aren't satisfied with the level of support they're getting. But I think that's the smallest cohort within that group, so that there are people who are resistant to it completely. Of those who are having virtual appointments, most are quite happy. I think that's what the comments support that. And just to pick up very quickly on the questions which don't suit your needs, obviously we don't set the questions, they're set by the CQC and NHS England, but we absolutely can feed back to them questions that you think don't work. The one about being seen is already in progress, but if there are others, do let us know and we will feed that back. And they do often change questions as a result of trust feedback, so do let us know.
Thank you, Charlie. I've got I see Mandy. Mandy, did you want to come back in on some of the comments Dean made?
Yes, please. It's really regarding our trust approach. We have a working group that's well established now, has been for the last couple of years, that meets on a quarterly basis, and it's made up of our unplanned and planned services, as well as patient service users and carers. And we look at the lowest national 20% scores that we've scored, but we also look at our trust bottom 5 scores as well. So it was just to reiterate that we don't just look at what we're scoring in that bottom 20% percentile, we're looking at our trust. So, and there is a robust action plan in place where we're obviously working on improvements, and we hope that will reflect in the next survey that starts February to June this year.
Okay, thank you very much, Mandy. And I have got Lynn, you had your hand up. Did you want to come back in again? Thank you, Lynn.
Yeah, I just wanted, Caroline, actually, if you don't mind, to put Paul on the spot a little bit. I am, like everyone, I think we've got to accept the context and the impact of the pandemic in relation to these scores. But personally, I was a bit disappointed, in some of the areas. And I've been reporting here, obviously, over the last year that this period of time was when we were implementing the CMHT transformation. So I guess just briefly, Paul, looking at the scores, probably those areas where we've done less well, can you comment on what we can expect in the next survey, particularly connected to the changes that we've made over the last year, please?
You're on mute, Paul.
Thank you, Lynn.
Right.
And that's just exactly why I put my hand up just before you, to say that, again, just carrying on from what Mandy was saying, we are looking at all of the scores, even the ones that we're doing extremely well, because we can always do better. And if you look at the theme of all of the questions in the context of the work that we're doing around CMHT transformation, our aim is that all the scores will go up. Obviously, that is what we're aiming for. And that's what we'd like to see in the next set of survey results. Some of the things that we're doing have been established throughout the last year. Some things are more coming onto line as we go along. So hopefully over the next year, the next 2 years, the survey results hopefully will reflect this. But some of the areas that covers quite a lot of the scores is around that involvement in your care, the reviews of your care, how involving of families. We've done a lot of work around our family inclusive care coordination for a couple of years now, which I think previously, if we look back a few years, you could see that things had improved. Obviously, it's not as still as improving as much as we would like, as we've just seen. So we're continuing that work around ensuring that everybody has access to appropriate training around family inclusive care coordination. But we've done a lot of work around looking at re-providing the current process of care programme approach. Now, the care programme approach, I'm sure most people know, is a national programme. It's around ensuring that people have appropriate assessment, reviews of care planning, reviews of care, and it's been around now for 1991, I think it was when CPA was first started to be introduced. As part of the CMHT transformation work, we've been tasked nationally as an early implementer site to look at different approaches. And we very strongly believe that the principles around good coordinated care and involvement is around that person-centred care planning approach. And that's something that we've had a work stream going on now for a while, which includes representatives from service users, carers, our staff from our organisation, but also from both local authorities, to look at how can we re-provide the care programme approach, getting back to those basic principles, but the most important principles about person-centred approach and a person-centred review and person-centred goal planning, which should fit into most of the things in this survey. If we can get that right and that proper, what it should be, that joint approach to reviewing and an assessment and to developing a goal-centred care plan, that will hopefully make a difference in our results. The second thing that I just want to quickly mention, and again is a focused area, is around that medicines management. And again, as part of our early implementer site for the CMHT transformation, we identified this as something that we felt was important going forward in our community mental health services. And we actually, as part of our model, we have implemented and put forward pharmacists and pharmacy technicians to be part of CMHTs, a part of that community mental health offer, which is something that's never been there. And again, the focus of that work is very much working with service users around med safety, ensuring that we've got kind of good reviews of medication and to contribute to that good reviews of medication, that medication concordance. And again, you can't have that medication concordance in how you take your medications, when you take your medications, without having that really good educational support and understanding of the medicines that you're taking. So again, our early results are we're getting some personal feedback from service users saying that they felt that has been really valuable and has made a big difference. We would hope to see some of that come out in the survey results going forward.
Thank you very much. Thanks, Paul. Michelle.
Yeah, good morning, everybody, and thanks, Charlie, for a great presentation. And actually, Paul said quite a lot of what I was going to say in relationship to the CMHT transformation and about developing a person-centred approach and a holistic approach to care. So articulated far better than I could by Paul, so thank you for that. So the two things for me I think that are really important is that, because this is probably with the staff survey, is the most important survey, because what our service users are saying about our service, so exceptionally important. I suppose the issue for me is the medication piece. I think we do need to bottom that and have a deeper look at it, because it does come up. There is a theme if we look at the last few years in relationship to medication and medication management in the community, and it's great that we've got the pharmacy technicians developing, etc. But I think we just probably need to do a bit more of a deep dive. I'll leave that with the quality committee, maybe to have a look at. One of the comments I was going to make was about our recovery college, because I think we've got a great recovery college that's growing, developing. I think we need to utilise that more to support and enable the work of the CMHTs, etc. And also to look at how the system can support, because if this is about access to follow-on services or other aspects of care, then we need to be working with the system in relationship to develop that as well. I think the other thing for me, finally, and I'll probably leave this again with maybe the exec team. We touched on it a little bit when we had the presentation to the exec team. I know the quality board will monitor the action plan, which is great. I think it's about having a suite of documentation to support staff in relationship to virtual visits and the digital offer, because we are going to continue that. We're actually benchmark reasonably on the low side in relationship to face-to-face appointments, so we're not high performing in having everything face to face. We're sort of in the bottom half of the pack for that, which I think is okay. But I think just having some things available now and some education and training for staff and support for staff as part of that, doing virtual consultations and how we can support patients during that, I think would be helpful. But I'll stop there, Chair, because I think it's a great presentation. I think people are going to say, I don't want to be average, because we want to be outstanding, and we're doing some things really great, but we've got to keep at it. This is so important what we do. Remember, patient-centred care is absolutely the core of what we do. This is what we're here for. I'm a nurse, I'm passionate about it, so we'll keep going. So thanks, Paul, for you and the team. And I know it's been a difficult during the pandemic, so some great results there, but certainly things to get our teeth into and to monitor and to develop across the whole of the spectrum, not just concentrating on little bits of it, but as we all do, that whole piece of the service offering. But I'll stop there, Chair. Thank you.
Thanks very much, Michelle. I don't think I can see any other hands up. So just to add my thanks to Charlie and to Paul and Mandy for your contributions this morning. Without repeating everything that Michelle has just said, it seems to me there's a few big takeaways from this. I think it's come up in the chat box as well about the issues around the understanding around the use of the virtual appointments in terms of the system, and that's for patients understanding what that means for them. But I think, again, a valid point made about the skills and the quality. And I think in the chat box, actually, I think a very helpful point was to say, actually, maybe we as a board should have some discussion about what becoming more of a digital organisation means for those people, particularly clinicians, who are having to use this more and more in the work they do. And I think that would be really helpful. I think also came up the medicines point as well. And you said, Michelle, there about it going to quality committee. We've actually had some good feedback about the difference it's making having our pharmacy technicians on wards for inpatients. This is another area we maybe looked in terms of that community support as well. And I think that's well made as well. And again, the other thing is people know who they need to see, and they are very positive scores on that. But it's how that then goes in terms of how they feel they are listened to and looked after. And I think the wider issues that affect their lives as well. I think there's lots of that today that is really helpful and positive about the work we're doing, but also some really helpful constructive points where we need to focus our attention. So thank you for that discussion. And obviously we'll make sure that's taken up in the action log. So thank you, Charlie. Thank you.
Thanks very much. Nice to see you all. Cheers. Bye.
Bye-bye. Okay, moving on then to my chair's report. Well, firstly, obviously, Stuart McKinnon-Evans is joining us this morning. He's our designate audit chair coming in February. So again, welcome, Stuart. His appointment was ratified by the Council of Governors in December. We were looking to recruit for a general NED at the same time. Unfortunately, we didn't feel we could make an appointment. This has been discussed thoroughly with our governors, and we're looking to start early in the new year to set that in trend again to appoint a general NED. It was disappointing, but we felt we made the right decision to look at recruiting again for that position. Some of the meetings I've had since last we met, I met with some of our CQC inspectors team, an introductory call with them to talk about their work and what support they give to the trust, as well as what a CQC inspection is about. That was really good to meet with them, and they actually made some points that there is some discussions again going forward about how some of the inspection processes might change in the future in terms of where they will go and the depth of the inspections they might undertake. I also met with Kate York, our Assistant Director of Psychology, to have a little bit of talk through about her work and the department's work. Helen Camish, the Community and Primary Care General Manager, that was really helpful actually, because of course, you know, often for the Trust it seems that obviously mental health is a really important part of what we do, but also the other part of what we do is our community and primary care services. And so it was really interesting to have an update there, and it made me come away and think about, which I'm not saying we're not doing, but just how much we find different ways to always not forget that primary care part of the work we're doing, particularly with our GPs and others, that they feel, because they are so spread out across the patch, that they see themselves as a first amongst equals when it comes to our services and the work we do. We had there's minutes for the last Council of Governors meeting in 21, but I recently had another Council of Governors meeting, which was very well attended. And just to let you know, if you don't know already, that Doff Pollard is going to be our new lead governor. We also have 6 new governors starting in February, and information and induction is being planned for them. And of course, we've had a group of very, very devoted and hard-working governors whose term of office is coming to an end, for whom I'm sure we'd like to express our thanks for the work they do. This does mean that there's quite a churn at the moment, and therefore I'm having to look at our governor committees and to make sure that we have new members coming onto those as well, but that's in train. And dates for the next round of governor elections is also underway. And just to add a further point, and obviously we've got vaccinations on the agenda, I have I raised it verbally with governors and had a discussion with them about it, but then I have formally sent them all individual letters to ask them to provide us with their vaccination status in line with the legislation and the rules governing mandatory vaccinations. So that's really it. Oh, and I visited the Humber Centre as well in December. So that's all from me. Are there any questions to me? No, thank you very much. We move on then to the Chief Executive report. Michelle.
Thanks, Jen. Another busy month then. I'm not going to go through the report as I don't normally. People have a chance to read it. I'll pick out some highlights, and then I'm going to set a bit of context and then ask Lynn to come in relationship to the COVID piece. I'll pick up a few highlights from the report, and then we'll pick up the Omicron and the COVID piece, if that's okay. There is a couple of there's 5 policies to approve, so please let's do that at the end. And also board voting. If you remember, when we were in that transition in relationship to NED appointments, we had an unbalanced board, so we at that point stood down the deputy chief exec and the coup from voting, because obviously the others are statutory members of the board. Because we've now equalised that, we haven't equalised it. We've got an extra NED, and I'm bringing to the board today for approval that we reinstate Lynn's voting rights in that, as always was. So it allows us to be more but back as we were before when we lost a couple of NEDs. There's a bit in there about the integrated care system developments. Lots and lots happening in relationship to the development of the integrated care system, even though the Act has been postponed until July. There's still some conversations in the House in relationship to amendments. A couple of those are mental health related, especially around funding, and it being really clear in the ICS what money is going to mental health services. We have supported those amendments, as you would imagine, from a mental health perspective. So that's why the start date has been pushed back to July at the moment. A very whistle-stop tour in relationship to what's happening. Obviously, we've got our 6 places. There's a potential change of name to North Yorkshire and Humber. That will be progressing. But in the places, in relationship to North Yorkshire and York, they're developing a leaders group, which I'm part of. The York are continuing with their alliance approach to place. North Links are just developing and having some thoughts about whether it's an alliance or whether it's more a committee type structure. North East Links, as we know, have been developing an alliance structure for a long time. That's continuing. Hull have gone down the committee route. So they're developing a shadow health and social care committee alongside exactly the same in East Riding. And each one of those places will have an NHS lead post that will report into the queue of the ICS alongside a place chair. So more on that later, but it's just important that we keep up to date with the ICS developments. Lots of work continuing with staff engagement. I'm continuing to do a lot of the virtual meetings, but also doing some face-to-face as the infection protection control guidance allows me to. You may or may not remember, I am the breastfeeding guardian of the organisation. I'm a health visitor by background. And it's just, I just thought it'd be useful just to put a bit of a report in there because we have maintained our gold status. Now, if you remember, being a gold provider for breastfeeding services is actually in the top 1% of all organisations, and that includes acute trust. It's a huge undertaking and it's a huge privilege to be there, and we've maintained that throughout the year, which is great. So there's a little bit of an update on that. There's also a list of staff support because we've had a couple of letters from unions about what we're doing to support staff during the difficult pandemic. I thought it was useful just to refresh the board in relationship to how we have been valuing and supporting staff, and we will continue to do that. And we've just sent out a communication about an extra annual leave day this year to say thank you. Pete, I'm sure, will pick up the planning guidance. And it's just great. I'm sure John maybe wants to pick up a little bit about the Digital Aspirant Plus because it's great that that work is continuing. And there's lots and lots in the comms section about our new background, which you will have seen, the brand centre that's developing, the New Year, New Job campaign that we're doing, and the couple of shortlisted for awards. Again, there's a Health Stars report in there as well. But I wanted to start off with those points and then hand over to Lynn because we've done all that and we continue to do all that in the backdrop of a horrendous pandemic that we still find ourselves in. Obviously, we've had the Omicron variant and possibly at the worst time of year because it came over Christmas and New Year. It's still with us. The numbers are plateauing, but we're still quite high. We're always a couple of weeks behind London. But because of, I think, of our business continuity, we've constantly planned ahead as much as we can in relationship to the pandemic, and I thank the teams for that. We have maintained relatively good services. They're all good, but we've maintained a good coverage of services, and we haven't had to actually stand down any across the patch. We've pulled corporate staff into the operational clinical areas alongside the clinical frontline staff. You'll see the COVID report, which Lynn will go through in a minute, but we have maintained services. We have had more COVID patients than before, and our sickness has risen quite substantially because of the Omicron variant. I'm going to stop there. I wanted to mention a few points and hand over to Lynn just to give you that overarching COVID piece, and then we can maybe pass over chair to anybody else who wants to ask any questions, or if any of my direct colleagues want to pick anything up from the report. But I'll leave it there and hand over to Lynn.
Thanks, Michelle. Lynn?
Yes, thank you. Thanks, Michelle. Thanks, Caroline. As Michelle's already said, it's been a very challenging few weeks to say the very least. Obviously, not just for us as an organisation, but obviously for the wider system as well. So obviously the background to the report obviously sets out that the NHS EI raised the national incident alert level in mid-December from 3 till 4. Some of you will remember that the alert level was actually reduced back in July, stayed at 3. So it's the first time it's been raised back to 4 again. And obviously that was specifically related to what was expected to happen nationally in relation to the Omicron variant. The fact that looking at what was starting to occur in London at that point in mid-December with the spread, the rapid spread of this particular variant, acknowledging that perhaps the impact on hospital admissions was not really understood at that time, but perhaps wasn't to be expected to be as high as it had in previous waves due to the vaccination position. But obviously the requirement that because of the impact of Omicron and some evidence that the 2 vaccinations weren't having quite the same impact on preventing spread. So therefore that obviously led to the focus on the rapid rollout of the COVID booster vaccination programme. We'll bring John in towards the end to talk about our particular role in supporting that programme, but obviously also to make sure that all systems were prepared, well prepared for expected increased admissions, hoping that those admissions weren't going to lead to significant or serious demand on intensive care, and hopefully suspecting that we weren't going to see the deaths related to COVID rise significantly. And obviously time has borne out that position. So that was all set out in a letter to the system, to providers, to trusts, by Amanda Pritchard, Chief Executive of NHS. Obviously we had already stood up our command arrangements at that point in time, also perceiving that the risk of Omicron was obviously increasing and rising. And obviously we have been holding our weekly gold, silver and bronze commands since then. They're still in place now, but also that the system stepped up its command arrangements too at that point in time. So we have had an increase in system-wide golds, silvers, happening, obviously to carry out and meet the requirements that were set out in Amanda's Pritchard's request particularly. So the impact from us, as you can see in the report, is that our COVID-related sickness absence did rise quite sharply. Our highest level of absence through the period to date was we tipped into just above 10% for a couple of days. Operational pressures at that time were high. Thankfully, it has reduced, it has stabilised. We've got the position today where we've got 46 incidences of staff-related absence due to COVID. That gives us an overall position of 7.61%. So it is better. We are varying between that sort of 7-8% position for the last couple of weeks. Through December into early January, our operational pressures were at Opal 3 continually. So that was through the Christmas to bank holiday weekends. Last week, we were able to reduce to Opal 2 and haven't quite got today's report, but looking at the position yesterday and what I know from early this morning, 2, I expected it to remain at Opal 2. Thanks, John. So that is good news. Michelle's already touched on, obviously, we have had to step up small elements actually overall of our business continuity plans. That's primarily been around prioritisation of clinical need and demand, not stepping down or stopping any of our services. They've all been provided right through this period, so that's great news. Caroline, I think as you have just commented around your meeting with Helen Camish, obviously a lot of the system-wide work has been predicated on supporting the acute hospitals to discharge patients, discharge service users. So it was recognised nationally that there are quite significant numbers of patients who are delayed discharge or don't meet the criteria, as we describe it now, to reside in hospital. So our community services in the North Yorkshire area have been really focused anyway, right through the pandemic, around supporting that pressure. But obviously the requirement was to step up that activity. So I have to say our services in that area, as ever, have done whatever they've needed to do, have worked, even harder, dealt with more increased demand in capacity to manage that, and are continuing to do so. And that issue has been right across our ICS area. So again, we've been not only focused on our own pressures, but obviously really working hard with our system as well. So we have seen the OPAL levels, particularly for the acute hospitals, predominantly actually for quite long periods at OPAL 4. And they are managing to de-escalate, but at the minute that pattern is for short periods before escalations rise again. That's been obviously having an impact on the ambulance services, particularly that handover time when ambulances are arriving at acute hospitals to pass patients over. So again, there's been a really good, strong focus around supporting that position as well. As Michelle's already said, we have seen a rise in the number of COVID positive patients that we've had. We've got 7 today. They are all actually in our secure services. So in the beginning of this wave, they were predominantly in our mental health inpatient areas. That's reduced. But we have got an outbreak at the Humber Centre. We are managing that very well. I'm sure you can appreciate that when we do have COVID positive patients, in order to maintain the isolation and cohorting of those patients, that requires additional staff for us to do that. So again, we have had our staff, working really hard and flexibly, and obviously within the COVID safe working infection control guidelines. Again, I'm going to appreciate the support of the infection control team who've been working incredibly hard over this period, because we have been again safely, but we have been needing to move quite fast around making sure that our cohort arrangements are also allowing us to manage our patient and bed flow as well, because we've needed not to put pressure on the wider system for having delays, for example, of our mental health patients potentially waiting in EDs if we've not had bed availability. So it really has been a challenging period of time. I think we've managed it as well as we possibly can, and we're getting good feedback from our system partners as well about the part that we're playing in supporting those wider pressures. I'll stop there.
Thanks very much, Lynn. Are there any other director colleagues who want to make any comments before I open it up to discussion? Pete?
Thanks, Caroline. So I think I'll just briefly touch on the planning guidance, which we've highlighted in the paper. So no real surprises. It came out on Christmas Eve. No real surprises in the guidance that are in there. 10 priorities, but some of the highlights are the focus on workforce and linkages to the People's Plan. Obviously, continued response to COVID. As expected, big focus on the elective backlog and recovery. Pleasing to see digital in there, and speaking as your finance director, we are seeing the reference to system productivity, and the efficiency agenda will be coming back into the planning guidance. As we sit here today, we're still waiting for some of the detailed answers to come out, and as always, the devil will be in the detail. We'll bring that back to the board next month for what our plans are starting to look like. And the current timeline, which is under review, are draft plans for March and detailed plans end of April. But as I say, that's currently under review given the national response to the pandemic that's been happening. Just a couple of others, if I may, and then I'll stop if anyone wants to ask questions. Great conversation in the chat box on digital earlier. You'll see in the paper, the update on where we are against our current digital plan, and we have made really good progress. So that does give us a really solid foundation for our ambition to be a digital future organisation. And obviously, Michelle mentioned Digital Aspirant Plus. We've dipped our toe in the water on the engagement on that, and obviously we've got some priorities to look for the first stage, and then obviously that will move on as we look to develop our electronic patient record. So just a few I thought I'd highlight from the report, Caroline. Thank you.
Thanks very much, Pete. I'm going to take a few questions, and I see Michelle Hughes has got a hand up. I'll come to you shortly, Michelle, but I'm going to take a few questions because we've had, Michelle, Lynn, and Pete making contributions there. So I've got Francis.
Thanks, Chair. Start off to say really thorough and detailed report, and great for the additional material we've had, and compliment the team on the excellent work on COVID that's gone on. It's been really impressive. A couple of things. First of all, just to make what's probably a fairly straightforward point, but there's a theme running through just about every paper today, whether that's winter pressures, IBR, safer staffing, etc., and today about the issues around sickness, staff vacancies, and the pressure on the workforce. It's just a common theme running through the whole of today's agenda, which we just need to be cognizant of. I know everybody is, but it's just something I thought I'd bring out. In terms of questions and comments, the first one was on the staff engagement. I see we've now introduced the weekly COVID calls, and I was just interested on kind of what numbers were attending. That was my first one. I'll do a couple and then open it up for answers. I thought the stuff on the breastfeeding was excellent, really comprehensive, and very beneficial to hear what was going on in terms of that and the way that that's going. As I said, excellent work on COVID. We got in here about the inpatient settings and visiting. I just wondered where we were on visiting, because I know a lot of the acute hospitals have actually stopped all visiting altogether. So I was just wondering where we were in terms of visiting. And then my final one was around the operational planning, and we've got the bullet points there in terms of the focus, which I know our whole board and everything is around them, but at some point it might be useful literally to have an update against each one of those bullet points that apply to us. So we're just comparing and contrasting how we're doing against those bullet points. We do it throughout the papers, but sometimes it's useful just to bring it together under one set of bullet points just to understand. So that was my key points. Thanks, Chair.
Thanks very much, Francis. Who'd like to pick up on those questions and suggestions by Francis?
Shall I start off, Chair, and then
Michelle, thank you.
I mean, I think, yeah, I've been doing a lot of, obviously, the virtual calls, which work out. Sometimes the individual teams, sometimes the individual team members, sometimes the larger, and that's been going all the way through for the last couple of years. There's a huge spreadsheet, and we've been around absolutely everywhere on a few occasions. So the numbers vary because it's team size. Sometimes I join a team meeting, etc. In relation to the extra weekly call, Ask the Exec, they've been quite constant, actually, of Ask the Exec. About 150, 160 people have been dialing in, but actually they all stayed through the session, which is really, really positive, and that's been really consistent. So we're going to continue that, whatever, post pandemic, we're going to continue with those. We did put some, you're right, Fred, we did put some extra ones in due to the Omicron and coming through Christmas, etc., and we were getting around 70 to 100 through it, which I don't think is bad. And actually the first one, which we put on at a really quite short notice, we was only for 20 minutes. We were still there 45 minutes later, which was great because we were getting lots of questions and informality. So I think that's really good. I'll leave Hilary to mention visiting. We can't have a blanket. We don't have blanket policies across the organisation. So we've got visiting guidance in relationship to our unit, but we still do allow visitors. But Hilary will give some of the precautions that we take, and we can pick up the planning and the performance as we go through the meeting. We are absolutely all over the information about workforce recruitment, etc. It is our number one issue that we are constantly looking at in relationship, not just the executive team, but all the way through the organisation, which is why we've done the new year, new job campaign, etc. And actually from a we are looking at it across the board in lots of different innovative ways, which I'm sure we'll pick up as we go through the session, Francis. But I'll stop there. I'll bring Hilary in